My son was laughing at me and my wife, you know, and so he was like, Mikey didn't like it.
Most people come up with nicknames for family or a pet, but Andrew Swindle has a nickname for his heart, Mikey. On today's All Things Heart, why he refuses to call it his. Good morning, I'm Jessica Lovell in for Alexis Del Cid. Welcome back to All Things Heart. Andrew Swindle was asked to give some final words at a city council meeting, and they almost really were his final words.
Hold on. Excuse us for a minute. We have a little medical emergency.
He collapsed in the middle of his speech and wound up being the first of his kind here at the health system.
It's been my honor to serve for the past 4 years.
That's Andrew Swindle speaking at a city council meeting in Derby, Kansas. It's December 14th, 2021.
Running for city council was my opportunity to give back to this community.
The Wichita State geology professor and another member have been asked to give speeches.
Two of us were running for re-election, and we both lost. And they had to stand up and give a little, farewell speech.
But Andrew's farewell speech is about to take an incredibly dark and almost literal meaning. As the mayor moves on to the next agenda item, you can see part of Andrew sitting directly to the mayor's left. Next, Andrew appears to clench his fist and start breathing rapidly. Then he disappears from the screen. Andrew has collapsed. His heart has stopped beating.
Excuse us for a minute. We have a little medical emergency.
The next thing I know, I was in the hospital.
Andrew believes he made it to the hospital alive for two reasons. One, the police chief, also at the meeting, performed CPR. Two, first responders happened to be watching the meeting live from the firehouse.
We have a little medical emergency.
They told me later that they were in the truck before the call came in. They packed me on ice and put me on a plane and flew me to Kansas City.
But the trouble for Andrew actually began more than 50 years before this frightening evening. When he was still in the womb, Andrew was born with a life-threatening congenital heart defect called TGA. Transposition of the great arteries. That's when the two main arteries leaving the heart are reversed. He had his first surgery at age 2 and gradually had to dial back physical activities as he grew older.
Basically had to scale it all down because I had episodes of SVT. It's where your heart races. It got into my 20s and I'd have these episodes and they started taking longer and longer to go away.
But life went on. Andrew graduated, got married, built a family, earned his PhD, became a geologist, and then a very proud geology professor at Wichita State.
There's basically not enough water pressure to fuel it. I taught the student in a soils class, and he said, I got a job because of your class.
And eventually he became a city council member, which brings us back to December 14th, 2021. Shortly after Andrew's heart stopped, he would also have a stroke and embark on one of the hardest journeys he has ever traveled in his 50 years, culminating with a type of heart transplant that had only been performed once before at the University of Kansas Health System. A transplant so complicated and so intricate because of his unique congenital heart condition, it required two surgeons from two different hospitals working side by side in the OR to ensure Andrew came out the other side.
And we are joined in studio by Andrew's transplant surgeon, cardiothoracic surgeon, Dr. Matt Danter. How are you today?
Good morning.
Good to have you. And we are really glad to be joined virtually today by Andrew. It has been just past the 1-year mark since your transplant. How are you feeling?
Feeling good.
Good to have you with us. We're glad to have you to learn more about your story. Andrew, Dr. Danter was the second ever congenital heart transplant here at the health system. What makes a congenital heart transplant different than somebody experiencing heart failure?
Well, typically, there's a number of things. First is that the patients typically have had multiple previous heart operations, which makes things a little technically more challenging. But their anatomy is such that they often require sort of reconstruction of certain elements of their anatomy. So their atria or their great vessels or something require further reconstruction as opposed to just take the old heart out and put a new heart in for someone who doesn't have congenital heart disease.
So let's take a look at this. On the left is normal heart. Explain the difference on the right, which is the heart with TGA.
Well, essentially what you have is the circuits are essentially disconnected. Usually you have the venous return to the heart goes to the right atrium, then the right ventricle out to the lungs, and then back to the left atrium and left ventricle to the rest of the body once it's been oxygenated. In DTGA, you basically have those fundamentally disconnected. So the venous blood returns back to the right side of the heart, which is actually the systemic ventricle, and it essentially ends up with these circuits being in parallel. So the ways that those have been fixed over the last sort of several decades, and as we were talking before the show with Andrew, we really stand on the shoulders of giants who were able to repair this. And in Andrew's reconstruction, they had basically what's called a mustard procedure, where they baffle the venous blood that returns to the heart to the left-sided circulation so that it could be pumped to the lungs, and then it gets baffled back to the systemic ventricle, which is actually the right ventricle, so that it can be pumped back to the rest of the body.
Incredible. Okay, so let's take a closer look at the heart with this condition. How does the heart adapt?
Well, you know, a number of things occur. One is that with this baffle that's placed so that they basically create a hole in the heart and then baffle the blood from one side to the other. Over time, as you can imagine, as the heart grows, that baffle can become constricted or narrowed, and it essentially works like a valve stenosis, or it essentially manifests like a valve stenosis. So the typical maladaptive features of TGA is that you end up getting arrhythmias related to the scars from having the previous surgery. But also, the right ventricle is not designed to be your systemic ventricle. It's not designed to, support the systemic circulation for someone's life. So you often get their systemic ventricular heart failure over time. And those are the two sort of principal maladaptive features of it.
So you had a congenital heart surgeon from Children's Mercy assist you in this transplant. What is it about these particular cases that are so complex?
Well, as we talked about, some of the anatomical features require that you have it. But Dr. Will Gibson and I have done work together on all of the congenital transplants that we've done here, and that's basically to make sure that we have two sets of eyes looking at the problem, and someone with his level of expertise in the event that we need to reconstruct the left atrial cuff, or as we did with some of the other ones, reconstruct the pulmonary arteries, and basically, it's not uncommon for this to be a two-surgeon procedure anyways, but I really do value having the expertise of someone like Will during these cases, because it's just two sets of eyes, two experienced sets of hands are better than one.
Absolutely. Yeah. And on that note, what would be the biggest risk, would you say, for children born with this condition?
Well, essentially, early on, there's a number of procedures that need to be done in order to maintain that you have some mixing that occurs, so that you have some way to get the deoxygenated blood to the lungs so you can oxygenate it and then back through to the systemic circulation. So initially what can happen is you get very, very rapid decline. Now, most of these patients are identified in utero, so that there is already a plan set in place for when you're delivered, so that they move to keep certain shunts open so that you can actually maintain oxygenated blood, maintain an ability to oxygenate the blood, and then maintain a systemic circulation that has oxygenated blood in it.
Andrew, again, just such an incredible story we're learning this morning. How did your family explain this to you as a kid?
I don't remember them ever actually explaining it to me. I just I grew up knowing that I'd had a heart surgery. And I don't know if they specifically told me they told me what the procedure was called, but I don't think they ever told me what exactly the procedure entailed. But I know that I was familiar with what the procedure entailed in, junior high.
As you got older, did you know that a transplant was a possibility?
No, actually.
Yeah.
Oh, well,
please.
Well, I was going to say I'd never heard of transplant being a possibility until my former congenital heart doctor, Dr. Mulhern, who was at KU, he made an offhand comment on one visit about about transplant being a possibility down the road, and he just made it. It was just completely offhand. Didn't never mention it again. So that would have been probably 7 years ago.
Well, we already have some great questions coming in, and if you have any questions, send those in on YouTube, Facebook, or the All Things Heart email. You can find links to those on your screen. Dr. Danner, does having congenital heart disease impact the search for a good donor?
Not typically in and of itself. We have to still, because people have had typically multiple surgeries, you have to make sure that they don't have antibodies, and it can sometimes complicate the immunologic factors we look at for a heart transplant. But no, I mean, the anatomical features are usually something that we can overcome, but sometimes we need to have, it gets relatively, I don't want to be macabre about it, but we need more aorta or more superior vena cava or something like that in order to make sure we have enough actual sort of tissue to reach where the sort of consequences of the anatomical variations result in things being spaced in different anatomical positions at times. But typically what we try to do is make it as much like a conventional transplant as possible.
How many of those have you been a part of, those types of transplants?
Dozens throughout training and through my time elsewhere, but this is why we have a multidisciplinary approach to these things, and we have input from our congenital colleagues and congenital cardiology colleagues, because it really does. This is one of the examples of where you need the multidisciplinary approach, because there are things that may come up that make the transplant process and even the transplant recovery period somewhat more challenging. We're fortunate that with Andrew that he was in great shape going in, and he did really quite well, and there were really no hiccups.
Andrew, that video of your collapse, that has to be hard to watch. What do you think when you look back and see that? I first have to ask you that.
I don't really know. It's just kind of something that happened, and it's in the past.
Yeah, well, I can see you wanting to put that in the past. It's just not often that something like that gets documented in that way, for sure. But you had a lot of things on your side. High quality CPR from the police chiefs that were at the meeting, the first responders that were watching that meeting before responding. Have you spoken with any of them since they helped save your life?
Absolutely. Absolutely. The police chief, actually, he retired soon after that, so I had to call him, but thanked him immensely. And then the first responders, I actually set up a meeting with the fire chief to go to the fire station, and my wife baked I think she made a bunch of cookies and brownies, and we brought those to them and sat down and talked to all of them.
Wow. Well, I want to get to some community questions this morning. We have several coming in today. Alex wants to know, how did having this heart defect impact your childhood? Did you have to miss out on any extracurriculars? What was it like for you?
It's hard to really say, because I don't know what it was like I don't have any reference, I've just always been like this. I would say that, it didn't prohibit me from doing any extracurricular activities, but it did kind of limit how thoroughly I could do them. So, for example, when I first started playing soccer and such, I could push myself so hard, and then I'd enter SVT, and I'd have to stop, and it'd go away. But then as I got into high school and I was more active, I didn't have any episodes of it at all. And then, of course, in my 20s, I started having the SVT again, and it, the delay or the time it took to recover from SVT kept increasing. Now at this point in time, nobody had ever told me that SVT was something you should go to the hospital anytime it happens. So there was that on top of it.
Lauren is asking, is this condition genetic? Do your children have it?
No. My understanding is it's not genetic at all, and my kids don't have it.
Yeah,
Dr. Dander?
Yeah, it's a lot about the genetics is not really even well known yet, but basically it's considered sporadic, meaning that it doesn't have an inheritable sort of pattern of disease. So it's actually, unfortunately, it's relatively random.
Stuart wants to know, how many different congenital heart defects are there?
Well, that depends on who you talk to. There's classifications of congenital heart defects, but if you really get down to the extremely complicated variants, some would argue that no two of those are really the same anyways. So there's multiple different categories and classifications of congenital heart disease. From typically it's cyanotic versus acyanotic, meaning you have deoxygenated blood circulating or you don't, and then they're broken down basically anatomically as to where they are. But there are a multitude of congenital heart defects.
Andrew, Tiffany is asking if you know anything about your donor.
No. I wrote a letter to them or to the donor's family, but they never responded, and so I don't know anything other than what Dr. Danter told me, which was he was about 25 years younger and a little bit taller.
A little bit taller, yeah. Do you hope to be able to connect with your donor family at some point?
I'll leave that up to them. That was a hard decision for them to make, and I'm glad they made it. But I would only want to meet with them if they want to meet with me.
Sure, and yeah, that is a question that just came in, Dr. Danter. How are donors and recipients matched, and what is that journey often like for?
Matched in terms of their suitability for transplant?
Yeah, matched, and then also after the match and with families.
And I think there's no right or wrong answer for this. It's as Andrew puts it. The donor, respecting the donor family's wishes is of paramount concern. In terms of how we match donors, it's basically blood group, size, and then ensuring that there's no reasons why we wouldn't utilize that organ, so coronary disease or some valvular abnormality or something like that. And then basically, those are the two, I would say, most critical sort of things that we look at, which is make sure that obviously it has to be a compatible blood group, and then it has to be of adequate size. In terms of how it typically works with getting people connected with their donor families, it's like this. We typically wait a year after the transplant has occurred, so that it's not fresh and acute, and also you make sure that everyone's doing well at that period of time. And then it starts like this. It starts as a communication through coordinators and basically letters and emails or something like that, where they connect. And then there's no right or wrong answer. People have, we had Mr. Frias on a week or so ago, and he's met the father of his donor and these kind of things, and that was what their journey was and what he wanted to do for that process. And like I said, I think there's no right or wrong answer. Yeah. I think we just sort of mutually respect the boundaries that the families wish to have.
We've seen it play out both ways.
Yeah, it is a tremendous gift, and I would imagine often a very challenging and difficult decision to make.
For sure. Sydney wants to know about Andrew's daily care. Any anti-rejection medication?
Yeah, standard anti-rejection medications. So typically involve, a potent immunosuppressive such as tacrolimus, and then steroid therapy, and a number of other sort of preventative and sort of maintenance therapies.
What do you want the big takeaway from this particular story to be?
Well, patients like Andrew are among a group of growing it's a growing patient population that end up requiring advanced heart failure therapies. And we've done LVADs in patients with congenital heart disease. We've done transplant with a congenital heart disease. The take home I would like to have is that we certainly rest on the shoulders of giants, the people who came up with the original procedures that have gotten us to the point where people are living well into their 4th and 5th decade of life. But that's not the end. And so for people who have congenital heart disease and may or may not be aware, like Andrew was, of what the potential therapies are, I think that I'd like people to advocate, I'd like their doctors to advocate for people with congenital heart disease to at least get referred and get evaluated for advanced therapies, because most of the patients are told they're going to need something done in their 4th or 5th decade of life, particularly with these essentially fantastic but palliative procedures. And then transplant it should be at least considered as a therapy for people who get to this situation.
And what will his long-term care look like?
I mean, Andrew's in great shape.
Yeah.
So I mean, he should have the best possible result from transplant, and really he's done fantastically well since then. So I mean, it should be the same path as any transplant patient. Really, we have to monitor for rejection and for graft dysfunction and other consequences of chronic immunosuppression. But really, he should be essentially as any other transplant patient, any other heart transplant patient.
Andrew, again, thank you so much for being with us and just sharing your story. We're just glad you're doing well. What do you want the takeaway from your story to be?
I don't even know where to start. I would. Man.
Take your time.
I guess I never really thought of much about what my story should be. I'm just I've adapted to taking it one day at a time and just trying to make the best of the situation. I was I feel like I don't want to say I was given the short stick in life, because I don't feel like that's the case. But it's not. Oh, I don't know. I honestly don't know. One thing I will say though is, heart transplant is a great thing. It's really changed my outlook. Before the heart transplant, I had an ICD. I was constantly having to, feel my pulse and check my rhythms, and always, have these episodes of SVT, occasional VTAC episodes. Living in fear of that ICD going off, because when it does go off, it hurts. It hurts a lot. And so with the transplant, all that's gone away. But at the same time, now I have to do all this care like Dr. Danter mentioned. I have to check for rejection, immunosuppressant, interactions with medications. And so, that involves a lot of blood work. You have to do lots of heart caths. And so I guess it's a lot. So one thing I would say is that, heart transplant, it is great, it is fantastic, but it's not the end of the journey. You still got more steps after that.
Well, we just appreciate you being here to share this step in your journey, and we thank you so much. And we're just, again, glad you're doing so well so far.
Thank you.
Thank you so much for being with us today, to all of our guests and to all of our viewers. And if you'd like to watch or share one of our previous episodes, you can scan the QR code to find a list to all of our shows next week on All Things Heart. From hospital to hospital, he bounced, never getting a viable treatment until he came here to the University of Kansas Health System. On the next All Things Heart, the clinical trial that gave this patient his life back. Thursday at 8. Coming up tomorrow on the Morning Medical Update. Expert care from the majors to Little League and every athlete in between. I'm Jessica Lovell on the next Morning Medical Update. We visit Surprise, Arizona as the Kansas City Royals wrap up spring training. Hear advice that applies to all ages from the head team physician. Friday at 8.